All we needed to do was, let's call it a partial laminectomy. And everything went exceptionally well. We removed some lamina, added bits of soft bone graft tissue from your hip to promote more bone growth, and we used some solid bone graft pieces for structural support as well.
Spinal instrumentation is the method of keeping the spine rigid after spinal fusion surgery, by surgically attaching titanium wire to the spine, in a way that redistributes the stresses on the bones, and keeps them in proper alignment while the bones of the spine fuse for posterior stabilization. This system threads wires into the space within each vertebra, instead of using a metal plate and screws to stabilize the fusion.
Well, old fella, it appears we are in a bit of a sticky wicket. The MRI discovered that you have a rare disorder called Syringomyelia, which has formed the syrinx from C1 to C7.
We are now viewing the comparison of an MRI from a sample case on the left, which is relatively small, compared to the patient's large syrinx on the right. The patient's syrinx begins at the foramen magnum, which is the large hole at the base of the skull, which allows passage of the spinal cord. The syrinx extends the entire length of the spinal cord, down to the conus medullaris, which is the terminal end of the spinal cord. Syringomyelia has a prevalence estimated at only 8.4 cases per 100,000 people. This is the posterior side of the neck. The surgeon will make an incision here to access the back of the spinal column. The first laminectomy will be at the C6 and C7 level of the spinal cord. After the procedure on your spinal cord, they will reintroduce the pieces of your bone and the soft tissue to reconstruct your spinal column. This is a close-up of the spinal cord. Here is the spinous process and the lamina. The surgeon will begin by removing the spinous process and continue removing the lamina until the spinal cord is visual and accessible. We can now see the syrinx. As previously mentioned, the syrinx or cyst expands and elongates over time.
Our plan, lad, is to make approximately a 2 mm myelotomy at the site of the dorsal root entry zone, at the 7th cervical vertebra.
A myelotomy is an incision in the spinal cord.
We will then introduce a 1.5 mm thick catheter into the syrinx, and placement of the distal tip of the catheter in the subarachnoid space.
As a review, one of the spinal cord's protective meninges is the arachnoid mater. The innermost protective meninges of the spinal cord is the pia mater. The space in between these two meninges is called the subarachnoid space. We can now see the syrinx.
Here is the introduction of the shunt into the syrinx. We are hopeful this will divert the cerebrospinal fluid from within your spinal cord into the subarachnoid space.
This laminectomy will be at the C3 and C4 level of the spinal cord. Once again, after the procedure on your spinal cord, they will reintroduce the pieces of your bone and the soft tissue to reconstruct your spinal column.
We will be performing another myelotomy, although this time it will be at the C3 level, to introduce your second subarachnoid shunt. Much to our surprise, as soon as we made the myelotomy at the C3 level, the syrinx collapsed. Even though the syrinx collapsed, we still decided to place the shunt. This is usually necessary to prevent re-expansion